Hi, it's Dr. Centeno, and welcome back to You've Got the Power. It's been a little bit of time since I've done this. About 2 weeks, I was down in at our licensed Grand Cayman site, and down there, internet is not quite as reliable as it is here in the U.S. So I didn't think it was a good idea to do one of these down there. Plus, it was otherwise busy because it's the first time we've been back down there in 2 years since the island just reopened. So today we're going to focus on CCI, or craniocervical instability, and headaches. And this is a popular topic because, number one, a lot of CCI patients or craniocervical instability patients have headaches. And number two is, some struggle to get a diagnosis of what's causing those headaches. So it should be a good one. As you can see, I've got a blog up here from my Regenix blog, and that blog is entitled, "What is a Proper Diagnostic Block Headache Workup?" And I have that one up because we're going to be going through some common causes of headaches in folks who have neck problems. So as we start this, or before we start this, I'm going to sort of talk for about 10, 15 minutes, and then we'll open it up to questions. You can ask me questions about this topic or any topic at all, because again, educated patients are patients that are more likely to get better. So I always try to see if I can educate patients as much as possible about what's going on. So we're going to start first with this concept of, if you've got a headache and have been diagnosed with craniocervical instability, where do you kind of take it from there? What are the thoughts here, and why? How do we translate those thoughts and getting to a diagnosis? So the first concept is, should we be doing a diagnostic workup in CCI patients, and or should we just treat the CCI and see if the headache goes away? So let's talk about that. So a diagnostic workup is trying to figure out which specific structure in the neck is causing headache. And in order to do that, you've got to do what's called a block. So you have to specifically, under imaging guidance, numb a structure and then see if the headache goes away. That's called a diagnostic block workup. Now, we could do one of those in every single patient who has craniocervical instability, but as you can see here, the list is pretty long of the things that can cause headaches. So we have all the upper cervical joints up top here, the C0, C1 facet joint, the C1-2 facet joint, the C2-3 facet joint. So lots of joints there. So that's 6 different joints that would have to be blocked under X-ray guidance. Again, blocking means numbing that structure. And then we've got greater occipital nerve, lesser occipital nerve, third occipital nerve, the third occipital nerve at C2-3, the third occipital nerve at C2. So just the occipital nerves there, we now have 4 of those that have to be part and parcel of that diagnostic workup. So we've got to either numb those out using ultrasound guidance and or X-ray guidance, depending on where they are. Then we've got the superficial cervical plexus underneath the sternocleidomastoid. Then we've got the supraorbital or supratrochlear nerves around the eye. Then we've got the auricular temporal nerve, which is right behind the TMJ here. Then we've got the C2 dorsal root ganglion, which comes out near the spine. We've got the C2-3 disc itself, the sphenopalatine ganglion, which is deep inside the nasal passages here, and then many different muscle trigger points. So as you can see, if we had to go through this list and block all of these different structures to try to find the one that's causing headache, it's going to be a very expensive, time-consuming process. So it's usually better to treat the CCI first and see if the headache goes away. If the headache doesn't go away, then we can jump into the concept of, let's do a diagnostic block study to see where we need to focus. Now, there are also some CCI-specific headache causes as well that aren't on this list. One of those is going to be intracranial hypertension. The problem with that one is there's no way to get to that diagnosis. There is no diagnostic test that exists that allows me to say with high certainty that intracranial hypertension, meaning that the cerebrospinal fluid up here has too much pressure behind it, is causing your headache. That test just doesn't exist. We might be able to get into imaging that could show what could cause intracranial hypertension. We could maybe even measure it in specific ways, but I don't know if that's causing your headache. I've got no way to confirm that. Same thing with the rectus capitis posterior minor muscles or the other structures in the upper neck that jack into the dura or the covering of the brain and spinal cord. There is no way to numb that out. Hence, those are always going to be two wild cards in trying to figure out the cause of headache in CCI patients. So to wrap it up, if we start with the idea of we've got a CCI patient with a headache, the best thing to probably do is to treat the CCI and see if the headache goes away. If that doesn't happen, we can go through this extensive diagnostic block workup. We can combine that with exam to maybe get a little bit better idea of which ones we want to start with on the list. But that could take a while and be very time consuming before we find the right structure that is causing the headache. And in CCI patients, we still have those two wild cards that we talked about, intracranial hypertension, and also things like the rectus capitis posterior minor muscle that jack directly into the dura. So that's kind of what I have to say about that. I'll go to some questions now. So if you want to start jumping in with questions, this is a good time to do that. Again, whether it's about this topic or any other topic, really doesn't make a difference. So let's go here to Jalal. Jalal, what are the complications involved in injecting the posterior longitudinal ligament or PLL? Why would you avoid it during a PICL even if damage is indicated on DMX or MRI? The posterior longitudinal ligament is a pretty big deal to inject. You would have to go through and through the disc or far anterior enough to be able to hit the posterior longitudinal ligament up top through the PICL, which comes in from the front. So Jalal is talking about the PICL procedure, which injects the ligaments that hold the head on from the front. So it just adds substantial risk to both of those procedures. The one procedure on the PICL side, we have to get very, very close to the covering of the brain and spinal cord called the dura in order to do that. And so that risks puncturing a hole in the dura or injecting intradural, meaning inside the covering of the spinal cord and brain. And then when it comes to lower down, we would have to inject through the disc and then poke it out the other side and the back part of the spinal canal, which risks the same thing. So again, these are higher risk type procedures. And the goal is to expose patients to the least amount of risk possible. So regrettably, that means that we always can't do what the patient wants, or at least don't want to start there, if that means exposing that patient to additional substantial risk. So Al, hey Al, great to see you. Thanks for the shout out. Centeno Schultz Clinic. It's been an advance. My headaches used to come on gradually, but now they start with great intensity. What could cause that? You know, Harry, I'd have to know a lot more than that, I think, to answer that question. So if you're on here, you may want to jump in and try to provide some more info. Stevie, which ligaments need to be treated for skull occiput sliding on C1? The question would be which direction we're talking about. So if the skull and occiput are sliding sideways, that could be the atlanto-occipital or alar ligaments. If that side sliding forwards, backwards, then a different set of ligaments, primarily transverse ligament, the nuchal and VDL ligaments back here, and the anterior ligaments between the atlas and the skull. So it all depends on how that is sliding and what evidence we have that shows it sliding in that direction, meaning we'd want to see that on movement-based imaging in order to get a sense of what needed to be treated. Justin, can low-hanging cerebellar tonsils cause headaches? If they were caused by trauma, would PICL or posterior injections possibly help? Yeah, Justin, I did a whole video on that might be good to watch, because what that video talks about is the idea that if we take 100 people off the street right now and we do MRIs of their neck and brain, we're going to see a percentage of those people who have never had a day of problems in their whole life about anything have low-hanging cerebellar tonsils, Chiari 0 and Chiari 1. So the question is, why do some patients who have that problem or have that anatomical variant have symptoms and others don't? So that's the first thing you need to understand. We're talking about a common MRI finding in normal patients. And that video goes into depth on what's happening there and why. So if you go to YouTube, see if I can do it here, and you go to my channel, easier for me. But if you go to Chris Centeno MD channel, what you're gonna, if you just search, let's search under CCI. And probably got a lot under CCI. Let's go CCI and actually let's do Chiari. Okay, so symptomatic Chiari malformation and CCI. So this is the video you're looking for, and this video will get into some of that discussion on why cerebellar tonsils with craniocervical instability may be an issue. And it gets into some new data that's theoretical on that concept. But again, low-hanging cerebellar tonsils are a common finding in normal patients. So we need to be very careful about saying that that's causing your symptoms. But there may be a crossover, obviously, between craniocervical instability patients that have that versus don't. And as far as which type of procedures would help, it really depends on what kind of instability we're talking about. Adrienne, are stem cells or PRP best for lumbar interdiscal treatment of an annular tear? Should asymptomatic tears always be treated with intradiscal injections, or should you try supporting ligaments first? Yeah, Adrienne, disc tears are super common, normal findings. So I wouldn't agree to treat a disc tear unless we knew that disc tear were causing problems or pain. So we don't treat asymptomatic disc tears generally at all. Justin, I recently had an MRI that showed partially empticellus syndrome. Is this common with CCI? Is it unrelated? Could be indicative of some other problem. Yeah, Justin, not common in CCI. So you definitely want to talk to a neurosurgeon or neurologist specifically about that issue and whether or not it might have some crossover in your clinical scenario. Centeno Schultz, it's been advanced by Carly Meyer. I was just diagnosed with CCI, but I've had it and the headaches for 3 years from a car accident. It's too late for treatment. Carly, generally not. I would say the average CCI patient that we see for treatment with the PICL procedure or other procedures is about 3 to 5 years out from their trauma. Now, we certainly see people that are decades out, and I do believe that has a negative impact on outcome. But when it comes to 3 years out, I'm not as concerned. Justin, I have a damaged myodural bridge. Could that cause headaches? Is that treatable with injections? So, Justin, it's not really possible to see the myodural bridge very easily or to accurately say that one is damaged or not. Now, there are rare times when we might be able to get enough slices through there to say that it looks abnormal, and then that would need to be correlated with exam and history. But assuming all that lines up, then yes, treating the myodural bridge, which is nothing more than a tendon, if you will, that goes from that rectus capitis posterior minor muscle into the dura, can be treated and is more commonly being integrated into treating patients with a CCI. Robin, I didn't realize until your recent live that you did so many blood patches. What are your thoughts on Diamox for post-blood patch rebound high pressure? We don't prescribe or use Diamox for issues with dural leaks, which is what we would do a blood patch for. Jay, I'm having my first PICL in May. Would it be possible to start this process of discovery with my headaches while I'm here for PICL, or would it need to be a separate process? You know, Jay, it's fairly intense, like I said. So just so you have a sense of it, you know, PICL would be obviously a bone marrow aspiration and then the procedure. Average headache workup is going to be between, if we get lucky, only 1 or 2 injections, all the way up to 10 different injections. And those injections would have to be done generally on different days, or at least staged so that 1 or 2 were done on this day, and then the next day some more, and the next day some more, etc. So probably, again, not really a great idea to do that. Probably much better to go ahead and treat you with PICL, see if the headaches go away. If they do, no harm, no foul. If they don't, we can always come back and do the workup, just because about 2 and 3 times we're going to get the headache solved by just treating the instability. Hence, we're saving the patient from lots of different procedures, or the 2/3 of those patients. Rob Long, do patients tend to still deal with cranial nerves having issues that give symptoms needing perhaps higher dissection? You know, Rob, it really depends on which cranial nerves we're talking about there. A common one for CCI patients would be cranial nerve 5. So we have done higher dissections on cranial nerve 5 in those patients with relatively good success. But again, you know, focus would be treat the CCI first, see if the cranial nerve issue goes away. If it doesn't, we can always come back and treat it. Adina Fira, according to Dr. Henderson, CCI can be evaluated on supine CT or MRI with flexion and extension with an accuracy of about 70% compared to upright flexion extension imaging. However, in supine position, the muscles are inactive and no longer restrict movement. This job is done solely by the ligaments. Can this generate artificially high translation numbers for supine flexion extension MRI? Well, there really isn't a supine flexion extension MRI at this juncture. Certainly, there are a few centers that try to do it. So what we're talking about is having a patient lie face up in a tube, and then using an artificial device to move their head and neck into flexion, and then move their head and neck into extension. Now, certainly you could get more translation that way because the muscles aren't active, or not as active as they would be with being seated. As far as getting to a diagnosis of CCI, about 70% of the time on upright MRI, that's not my experience at all. At least CCI that I would treat. But again, my CCI criteria, I think, is stricter than many of the neurosurgeons treating CCI. So we can't get there 70% of the time on upright imaging. I think upright imaging with flexion and extension is a great technology. It's a great addition, but it doesn't always get us to be able to make that CCI diagnosis. As I've said before, DMX, or digital motion X-ray, is more likely to get us there to that diagnosis. But obviously everyone's going to be different in how they diagnose CCI at this juncture. But as far as supine flexion extension, I don't know of a lot of centers that do supine flexion extension, primarily because it's difficult to pull off. If you're going to get a flexion extension MRI, you should definitely do it upright. So I would agree with that general concept. Nicole Chantal, I had the PICL treatment 1 month ago for my ALAR. When should I begin simple PT clock on wall? I still cannot nod, and I feel unable to do Zoom calls. Is this normal for CCI? You know, as far as normal for CCI, it depends on kind of functionally where you are or where you started. We wouldn't expect to see any improvement in your symptoms till month 3 or month 4 after the procedure. So we've got quite a ways to go there. As far as doing the exercises, we don't recommend anyone do those exercises until they get cleared by their treating doctor who did the PICL procedure. So the answer to the question is no on the exercises at this point. And then number 2 is we wouldn't expect to see any improvement till months 3 or 4. So way too early for us to really look at whether or not that first PICL moved the needle or not. Roger, have you noticed permanent injuries to the brainstem or other structures even though the CCI was fixed? For example, leaky brain, is there a long recovery time for those other structures? Permanent injuries to the brainstem or other structures even though the CCI was fixed. Well, there's certainly, Roger, that this video that I have up on YouTube, you really should go look it up and watch that, because I think that talks about that concept, that in those research-based and theoretical papers that I talk about in that video, they are discussing the idea that in some patients, enough trauma to that upper cervical spine leads to damage in those upper cervical structures, including the brainstem and spinal cord. And that's generally not due to direct static pressure, although there are a few patients that have enough direct static pressure to have that be a concern as well. As far as leaky brain, that would be a dural leak of some sort and would most likely be a skull base leak. There are doctors that focus on skull base leaks. So you may want, if you think you've got that, you may want to get that ruled out. That would be something like having cerebrospinal fluid come out of your nose or ears. That would be very different from your average nasal discharge due to allergies or illness and that kind of stuff. Stevie Ann Williams, can someone who has collateral veins still have posterior PRP or stem cell injections, will these collateral veins hinder treatment? Stevie Ann, I'd need to know more about what you're discussing when you say collateral veins, meaning collateralization is a medical concept of when the main vein is blocked, or same thing with arteries, then little veins or arteries grow around that area to try to continue the blood flow. So I need to know specifically where there's thought that you have collateral veins to be able to answer that question, because that's not clear. Justin, would the skull sliding on C1 as shown on my DMX be a possible cause of neurologic symptoms? When I look down, I get a massive flare of head pain and neurodysfunction at PICL in 2020, but we didn't do above the atlas injections. Yeah, Justin, I'd need to know more specifically about your case in order to really say whether or not going above the atlas would make a difference for you. Certainly, any motion that is causing the dens to move backwards into the spinal cord or causing the skull to move on the atlas could cause irritation of the brainstem in the first case or cranial nerves in the second case. Adrienne, my question about disc tears was for symptomatic annular tears. My husband has significant pain at the levels of his tears. Should he go straight to intradiscal or treat supporting ligaments first? Yeah, Adrienne, the biggest concern there would be is documenting that those tears, which are 95% of the time asymptomatic, are causing that pain. The only way to do that is what's called discography or discogram. So discography or discogram is where the doctor goes in and puts a needle in the disc and then pressurizes it. It's a little bit like pressing on the disc to see if that particular disc is causing the kind of symptoms that that patient reports. Now, if that test is done and it shows that that disc is painful, then that's a reasonable time to treat those annular tears. But just realize only a small fraction of annular tears are going to be symptomatic. Anya, hi, sorry, we're going to ask questions somewhere. Yeah, Anya, just if you're on YouTube, I think you just put your questions in the comments there. That one I haven't tried out yet. You could also just go to Facebook and go to the Regenix page. So if you go to Facebook and you type in, I'll do it right now, RE. So let's go to Facebook here first. So Facebook. Then we'll go up here on the search and we'll type in Regenix. And Regenix just comes up here. Click on that. And you'll get to our page and should see this Facebook Live where you can go and put some comments there to ask some questions. That's a little weird seeing an image of an image of an image. It's one of those things like you're looking into a big mirror there. Okay, Daniel, can you tell us about cultured stem cells of Cayman Islands? What's better with those stem cells than those need to be injected the same day? Yeah, Daniel, the biggest difference in the cultured cells in Grand Cayman is that we can get a lot more of them and that we can save them for future use. So that would be helpful in patients that need lots and lots of areas treated with stem cells, or in a situation where someone is needing a much higher dose of stem cells than we can provide in a same-day treatment, because that specific diagnosis does better with a higher dose. When it comes to CCI, we generally don't treat CCI patients in Grand Cayman just because the setup there is not as robust as it is here in Colorado for that purpose. Now, who knows? That could change at some point, but right now we're just getting back on island. We're just reforming our team. Thankfully, our rad tech is the same one that we had previously, so that's a huge help. But we don't have the equipment there to do the PICL procedure in Grand Cayman, so that's not an option at this time. Justin, I had a full MRI workup with Dr. Rosa and radiology report I got that says I have damaged my dural bridge. Assuming that's correct, would that cause symptoms? Yeah, again, Justin, the concern there goes back to what does a normal myo bridge or myodural bridge look like? And we don't have much research on that. So we may have someone's opinion that says that one doesn't look normal, but we don't have any research that says we've looked at hundreds of myodural bridges in normal people, and this is what they're supposed to look like. So that's just a breadcrumb or a clue that we should take a look at your myodural bridge and see, for instance, if that's where your pain localizes, treat it to see if your symptoms get better, because that's pretty easy to do here in Colorado, that kind of thing. But I don't think we can hang our hat on the report at this juncture and say there's a 100% chance that the myodural bridge is causing your headaches. It's just a breadcrumb or something that we can look at and say, aha, we should take a closer look at that issue or problem. Justin, if empty cellulose syndrome is not common in CCI, could be indicative of some other conditions, CSF leak, intracranial pressure. I've Googled it, but the information I found is confusing. Yeah, Justin, it's just not a common thing that I see all day, every day. We've had a few patients with empty cellulose syndrome. As far as whether or not it causes any symptoms at all at this juncture, I would say, regrettably, you're outside of my area of medical specialty there. Stevie Ann Williams, can ligaments heal on their own at all? Sure, Stevie, so let's take ankles, right? We've all probably turned our ankle and it swells up for a couple days and we live around for a couple days and then it's not a problem. Now, in most of us, it heals permanently and pretty well. In some of us, it heals well enough, but it's still, ligaments are still loose. And at some point in the future, we'll get ankle arthritis because of those loose ligaments. But for the most part, we get one bite at that healing apple. And once we get our one bite at that healing apple, then it either heals or it doesn't. But ligaments heal in the body all the time. Arlena, I'm not sure what you mean by headache on fibromyalgia. Fibromyalgia patients, and that's an old term, it's now called central sensitization, are patients that have abnormal nerve input responses to things that aren't generally painful for most patients, meaning they've got an inability to inhibit those pain responses. So a lot of fibromyalgia patients or central sensitization patients do have headaches, but if I'm missing the point there, what you're trying to convey, feel free to jump in with some more info there. Adina, can PICL increase styloid to C1 distance by realigning the atlas? I don't know that the styloid to C1 difference means a hill of beans to me at all, meaning that we're talking about active concepts, right? So instability means that when something moves, it moves too much. Now, there are certainly some measurements where on static pictures, like you're talking about, where we can say that doesn't look normal, so that could indicate instability. And then you have a movement-based image that shows instability or doesn't show instability. But as far as a C1 to styloid distance, I don't really care, meaning that if there's a problem with instability, for instance, the craniocervical junction that's then banging into, let's say, impinging arteries or veins near the styloid process, that's something more interesting. But as far as the distance and realigning the atlas, not important in my book at all. Rob, she means collaterals in regards to vascular tortuosity, where on CTA it looks massive amounts of vessels surrounding the area one needs to be injected. Yeah, Rob, I'd need to know more about what it is specifically you're talking about. We're talking about the vertebral artery. We're talking about arteries or veins in the brain. As far as distended veins in the neck, around the internal jugular vein. So I need to know more of what we're discussing here to understand what it is you're asking. Nicole, can thoracic outlet syndrome improve EM width? So that one, Nicole, I don't understand. So maybe if you could double back around with that one, because there may be just some typos in there, Nicole. But thoracic outlet syndrome is common in patients with PICL or patients who get treated with PICL who have CCI. Thoracic outlet syndrome in general is a common thing to see in patients with, for instance, neck and upper back pain. Adrienne, regarding your response to someone else's question above, I tried to catch your answer, but you say that occipital could be treated to help side-to-side sliding. Yeah, so Adrienne, the occipital ligament is the ligament that goes from the far outside part of C1 up to the skull. And let's see if we can find a picture of it. Let's see what we got here. This netter picture is a good one. I don't know how big that is on your end. Trying to see if I can find a nice juicy one to look at, but this may be the best one. So anyway, we're talking about this ligament here. So this is the skull up top here, and this is C1. We're talking about the ligament that goes from the atlas up to the skull, and that can be injected as part of a PICL or even posterior injections. And that's one that we're injecting much more commonly these days, now that we've kind of perfected the injection technique, meaning there is no standard prolotherapy technique or anything like that that would allow you to inject this ligament. It's a procedure that we developed under X-ray guidance to inject it. And the reason why it previously hasn't been injected is the vertebral artery runs through right here. So you've got to stay out of that vertebral artery. You've got to know where it is. And in addition to that, you've got to have something on the C-arm like digital subtraction angiography that would allow you to make sure you're not in that artery. But I would say right now in the PICL or posterior procedures I do, it's probably getting injected in 50 to 60% of those patients, in addition to all the other ligaments that we're focused on. Nicole, can thoracic outlet syndrome significantly improve with the PICL? I'm unable to raise my arms, and the TOS showed up on MRI. So thoracic outlet syndrome can improve with PICL. And it's, let's see here, let's bring up some pictures. The best way I like to think about all of this is if you've ever seen a sailboat, right? Sailboat mast has guy wires that come out the side. Those guy wires, they've got other names, but we'll call them guy wires to keep it easy, in order to hold up the mast and keep it stable. So in the same way, we've got these scalene muscles that attach into the ribs here and go up to the mast that is the neck. Now, if I've got too much instability up here, the first thing that's going to happen is that the muscles that can provide stability that aren't supposed to are going to jump in, and they're going to try to help stabilize. And so frequently that's the scalenes. Now, the scalenes are also the walls, if you will, of the thoracic outlet. So if we go to this picture, we can see here that we've got the posterior scalenes and the anterior scalenes, and right between that is the thoracic outlet. So if you've got CCI and all of that up there is moving too much, and the scalenes jump in to try to help stability, but they're not designed to do that, that's going to reduce the size of the thoracic outlet here, which is then going to lead to symptoms. Now, if we get rid of the instability up here, the scalenes don't have to do that as much, so they're going to not be tight all the time. So that's the relationship. Levon, is contact sports post-treatment forbidden, advised against forever? Levon, if we're talking about treating craniocervical instability, then contact sports aren't going to be the best, that's for sure. One of my early patients, the best I can say is one of my early patients was a judo master who had a judo studio, and she would do what they call grappling, which is basically throwing people around. And she was a traumatic CCI patient in a car crash. She had it for several years. We treated her. Ultimately, she went back to grappling. Now, haven't followed up with her in a number of years because that was early on in our PICL experience, probably 2017 or so. But as far as I know, I did ask about her through her treating physician, who was Evan Katz, and he stated that she was fine, that she was still running her. I'm not sure if it's called a dojo, if it's judo, I don't know, but she was still doing all those things. So is it possible? Yes. Would most doctors tell you it's a good thing to do? No, they'd probably say it's not a good thing to do. But again, she did it. Rob, post-injections in upper cervical, PICL, or C0, the weeks following, should one limit movement, use collar, and any movement the way of the head is will still translate, i.e. ankle illustration, heels, brace and limitation, not so easy with the head. Yeah, Rob, so the biggest problem and the biggest difference with bracing an ankle and bracing a neck or a head is that if you brace an ankle, you can still, if it's done right, you can still have the muscles participate in stabilization to a certain degree with walking. So you're not going to get a lot of muscle atrophy, or at least the muscle atrophy is going to be mitigated. However, if I put a brace on you and you can't move at all, then 90% of the muscular work of those neck muscles, which provide stability, goes away, and those start to atrophy. And realize that stability is half ligament and half muscle. So it's a two-edged sword. We might get maybe some faster ligament healing, but we're going to be destroying the muscles we need to stabilize. So when push comes to shove, we try to keep people out of collars as much as possible. Now, we do have patients that use them on an intermittent basis when they're traveling, when they're in a car, that kind of stuff. And I think that's fine. Or if you want to use one when your head feels particularly flared up for half an hour, or something like that, that's fine. But as far as keeping someone in a collar while they heal post injection, it's not recommended for those reasons. Bobby Kellen, the live stream, not quite sure what that means. Maybe it's pinging Bobby Kellen. Daniel Iverson, can C vitamin help ligament healing? Yeah, Dan, I think there's some concept that if you're deficient in vitamin C, that used to be called scurvy, and scurvy would happen on long ocean voyages. And one of the things that happens in scurvy is that the person has a breakdown of their collagen. Now, these days, I think if you're taking the average multivitamin, you have more than enough vitamin C to produce normal collagen. And we really don't know that adding additional vitamin C makes a huge difference there. So I don't think you need to add vitamin C to get ligament healing. But if you're deficient in vitamin C, you definitely want to correct that. Levon, which do you prefer more to check for instability, DMX or upright MRI? Yeah, so Levon, as I was saying, for us, it's all about what's the likelihood of getting to ruling in or ruling out a CCI diagnosis. And because that's what most patients want to know, right? At the end of the day, when I see a new patient who I think may have CCI, they're coming to try to see, hey, I've read about this online. These symptoms seem to match what I got. So do I have this or not, doc? And if I had to pick one of those two that is more likely for me to get to that CCI diagnosis, in a patient that then requires that PICL procedure, it would be the DMX. Now, that doesn't mean I can't get there in some patients on the upright MRI with flexion extension, because I can. It's just a bit less likely. Now, listen, if you had the ability to have both, that's wonderful. If you had the ability to only do one, it would be the DMX in my book. But I will need to see some sort of cervical MRI, meaning routine cervical MRI, just to make sure we're not dealing with something really bad that we would all really not want to miss, like tumors, that kind of stuff, big disc herniations, nerves being crushed, et cetera, et cetera. Vascular, tortuous, arterial. Okay, Rob, I'll take a look at that. But again, I need to know specifically what we're talking about there, because sometimes a tortuous vertebral artery may be what you're talking about, and that can be seen in some patients and that have CCI. So maybe that's what we're discussing here. Stevie Ann Williams, can PICL cause the C1 or C2 to rotate? Don't know how that would work. Again, the C1, C2 is rotating because of loose ligaments. So if we tighten those ligaments up, we'd expect to see less rotation. Now, it's certainly possible that the vectors for treatment, i.e. for NUCA chiropractic or AO chiropractic, may change because the ligaments are tighter. But as far as causing rotation, we wouldn't expect to see that. Rob, back to hydrodissection 1, how do muscles respond to such? Is something that you do after a series of stabilization treatments? Yeah, Rob, so I think we're talking about nerve hydrodissection. And when it comes to nerve hydrodissection, frequently the nerves live between the muscles. So they're usually in those compartments that are where muscles come together. And so the muscle isn't directly treated there, other than the muscle fascia may be, because it's usually 2, but oftentimes 3 muscles that come together that form a canal, and that's where the nerve runs. And then as far as when we do it with a PICL, if it looks like the nerves are involved, we may do it out of the gate. If it looks like there's just mild nerve irritation that's likely due to the instability, we won't do it until after we're convinced that the nerve issue isn't going away once we get stability. Nicole, with CCI, it's important to sleep on your back for healing after the PICL. You know, Nicole, if you're comfortable sleeping on your back, and that's always been a good position for you, then I would say get back to sleeping in that position. However, the big problem with sleeping on the back for a lot of patients is that if they're going to obstruct their airway, that's the position where it tends to obstruct. So that then leads to sleep apnea or snoring, and that then adds a whole other potential thing into all of this, right? If you've got sleep apnea at night, you're not exchanging oxygen normally. If you're not getting a lot of oxygen at night, that's definitely going to impact healing of all sorts, including this. So I would say that if you can sleep on your back comfortably, then yes, that's a good position to be in. But if you're one of those people who every time you sleep on your back, your partner says, hey, I couldn't sleep last night because you were snoring, then don't do that, because that's going to really cause a problem on the healing side, because it'll lead to sleep apnea. And again, that's the most common position in patients who have sleep apnea, and a lot of CCI patients have sleep apnea, for them to close off their airway. Adina, if DMX is not available in your country, would flexion, extension, lateral bending, rotation x-rays be good enough for CCI diagnosis? Usually not, Adina. What I have seen is some of our European patients who get open mouth views with lateral bending and as far as they can go, where there's a visualization of C1, C2. So let me see if I can find that for you here. This is the kind of open mouth view that I'm talking about. So you can see that this guy's got his mouth open, and they're imaging through the open mouth, front to back or back to front, called what we call anterior posterior or AP. And you can see C2 and you can see C1. So if they can get that kind of image, and maybe screenshot that now so that you can show that to them with lateral bending, left and right, and then normal flexion extension x-rays. But again, every motion has to have the maximal amount of movement. And that can be sometimes hard for radiology techs to accept, because they generally get in trouble if they hurt the patient, or if a patient says that they have a lot of pain after an x-ray. So they tend not to want to push patients to maximal movement. So if I can get maximal motion, inflection and extension, and then this kind of open mouth view with maximal motion and lateral bending to one side and then the other side, that could get us close enough to a CCI diagnosis. Another thing, obviously, would be getting upright imaging. And there's the London Moderna C. Let's see, there's an upright MRI in London that does a lot of imaging. I believe this is it, but I'm not 100% sure. So I believe this is the one we've sent patients to in the past. So that's another thing to consider, is getting an upright MRI, whether in your country or in the UK. Edwin, I have a question about stem cell injections in general. Isn't there a risk that a stem cell injection in the area that has scar tissue will grow more scar tissue? Recently, an ankle arthroscopy largely removed built-up scar tissue. This from a provider who also provides PRP and BMAC injections. I asked him about them as part of the surgery, but he said they don't do that because they're at risk of growing scar tissue again. I would say that the provider who was doing that procedure doesn't know a lot about this area of medicine. Again, your average orthopedic surgeon, foot and ankle surgeon, podiatrist is going to know enough about stem cells to put on a small sheet of paper. So the answer is not really, unless you're talking about someone who forms severe scarring. So that would be something like keloids. So this is a person who, if they get a cut, they get a large hypertrophied scar. Now, in that patient, we may be cautious there, but that would be an extremely rare thing. If you've got a lot of scarring from an ankle surgery, it's probably from the ankle surgery. And again, I wouldn't generally trust what orthopedic surgeons or spine surgeons or foot and ankle surgeons are saying about stem cells at this point, because again, what they know could fill a small single sheet of paper. 1 or 2 paragraphs is all they know. So we're not talking about someone with a lot of experience in that area. What is best sleep position? Beverly, the answer is the best sleep position is very different for different patients. It all depends on where they're unstable. So we've had patients that can only sleep on their back, patients that can only sleep on the right side, patients that needed specific kinds of pillows and not others. We've had other patients that need to wear a collar at night just to be able to sleep. We have other patients that can't tolerate lying down at all, and they've got to be in a recliner type position. So it's so individualized, it's hard to say what's best for you. Levon, it's hard to do for a CAT scan of the cervical spine with contrast. Can the results be used for a clinical picture? I keep in touch with your clinic, sending image I get done locally. So, Levon, there are types of CAT scans that may help. So that would be a CAT scan with C1 and C2 rotation, but you've kind of got to know how to do that particular one. So that might be helpful in getting to a CCI diagnosis, but it's not generally what we would use. The other problem with CAT scans is they have a tremendous radiation exposure, generally equivalent to about 100 chest x-rays. So we try to keep patients away from CAT scans unless there's some pressing reason to do them. Edwin, related question, is thickening of the tendons leading to problems, also risk of stem cell injections? I had surgery ankle a few years back where the doctor described it. Problem was my peroneal tendon had become too thickened because of repeated injury. Yeah, so Edwin, I think, again, you're thinking about this all wrong. So tendons become hypertrophied, which is what you're describing, because they're failing to heal. So that's a normal tendon response. Everyone has that same response. It's called tendon hypertrophy. So cutting away a third of the tendon makes no sense, because the tendon is in fact getting bigger because it's trying to maintain its load to failure. What I mean by that is, let's say we have a tendon and it's going to fail if we put more than 300 pounds of stretch on it. And that tendon gets injured. So it can't fully heal itself. So it just throws more tissue at the problem to maintain as much of that 300-pound load to failure as possible. Now that's called hypertrophy, and it happens in pretty much everybody out there. Now taking away a third of that tendon thickness wouldn't make no sense, because we'd make the tendon a third weaker if we did that. What we really want to do is to stimulate healing within the tendon so that the tendon becomes smaller and denser and has the same or a better load to failure. So again, that's what I would call surgical craziness, meaning that, and not understanding why tendons get thick. They're not getting thick because they're pissing off the surgeon. They're getting thick because they're trying to throw tissue at the problem to maintain their strength, but they're not as dense. They're less dense. So we want a dense tendon. So that means we want to stimulate repair in the tendon, not cut out part of it. Hope that makes sense. Bev, thanks for saying that. Rob, you spoke of NUCA, AO. What is suggestion about getting treatments from a regenerative process? So there is no issue at all with doing NUCA and AO during upper cervical injections that we perform, whether that be PICL or posterior. When it comes to PRP and other types of things, again, no issues whether it's PRP or bone marrow. CBP, which is curve restoration, could be a different story in that some patients with CCI can't tolerate CBP. So I've got other videos, I think, more specifically on that, but that one could be a question mark depending on the patient. Nicole, I've also been diagnosed with stenosis between C1 transverse process and styloid with vertebral arteries potentially. So the vertebral artery is back there, so that's not going to get compressed between the transverse process and the styloid. If you're talking about stenosis between the C1 transverse process and the styloid, that has to do, and you're not really talking about likely the styloid. You're probably talking about a calcified stylohyoid ligament, meaning if you've got elongated styloids, then that's different than the styloid. So it might be good to look up this blog. So if we go to regenx.com and you go here to the blog, or you can just search it. So let's search it. So if we put in STYLOID process, I think we got to press the search there. So what is Eagle syndrome? That's a good one to look at. Also jugular vein compression to the neck and CCI. So those are two good ones to look at and really explore. So when it comes to Eagle syndrome, you know, the concept here, and I think I've got, well, sorry guys, I'm gonna have to go back in and add back some images there. Our web team regrettably kind of took out some images inadvertently. Let's see what we've got here. So here's something to look at. So let's look at this. So we have here the C2, and we have the styloid here and other structures. And the concept is when the patient is moving, that can get, then the internal jugular vein can get compressed. Now, when the patient's in a different position, that's not compressed. So this is a dynamic concept. It's not something that we can measure on a static image, because the problem with measuring in a static image is we're going to see lots and lots of people in that group who don't have any symptoms at all, but have the same small area. So maybe what we could say is that a smaller area between different structures might make the person more susceptible, but it's with movement that we're talking about these things. In this case, craniocervical instability. So the goal here is not to cut out bone, because that would be an inelegant, invasive solution to this. The goal here is to tighten down ligaments to see if we can get this dynamic compression to stop happening. So again, the goal here is if there's CCI, to treat the CCI. The Eagle syndrome really has to do with a portion of the stylohyoid ligament, which becomes calcified, and then things might get compressed with motion. But that stylohyoid ligament is a critical part of stabilizing the anterior neck. So if we take it out, we're going to destabilize the anterior neck. Now that might be needed, it's possible, but it would be the last thing we'd want to do in the list of things that could be done for that patient. Stevie and Williams, Edwin, thank you. Stacy. So guys, just want to let you know, I'm coming towards the end of the hour here. I've got another following meeting, so I'm just going to take another 3 or 4 questions, and then then I'll probably shut it down for today. I will be doing this on Friday again. The topic on that one is going to be a little bit more focused on other things other than CCI. But again, you guys are always welcome to ask as many CCI questions, regardless of what I'm talking about. Stacy, would you be able to specify, looking at MRI and DMX, which part of the cervical spine is causing violent dystonic episodes? Yeah, Stacy, generally not, meaning that CCI can sometimes cause dystonia, and or that may be other things causing those problems. So probably not. Beverly, if I move my neck in several certain ways, my blood pressure and heart rate bottoms out and almost pass out. Pacemaker was placed to protect heart from stopping. I have not addressed CCI. Yeah, so Beverly, that is suspicious for looking at something like CCI. So, yeah, the best way to do that would be getting imaging and obviously seeing a doctor that specializes in CCI. So starting with a telemedicine consult would be a good place to start. And then from there, we could either order some studies or you could get a DMX and then a telemedicine, realize that, if you don't have imaging, we'll have to get imaging and then circle back around, that kind of stuff. But all of that probably needs to be looked at then as a possible neck issue. And that would be exploring CCI as well as other things. Levon, you've mentioned tremendous levels of radiation with CT scan, but is DMX also plenty of radiation? No, not really. So we're talking about really different levels there. So the average DMX may be 5 to 10 chest x-rays, and the average CT scan 100 chest x-rays. And then CT angiography. Again, if there's a reason to get CT angiography, then we should definitely get it. If we're really grasping at straws, trying to figure out what's going on, it's not appropriate until other things get ruled out. So it all depends on the clinical picture. Obviously, I can't diagnose you over the internet, nor would I try. But I think it's important to just recognize that if we're looking for a very specific problem that we suspect is there, meaning at least a 5 or 10% chance it's there, then exposing that patient to that radiation may be a reasonable thing to do. But if we're grasping at straws and we don't have any clue of what's going on and an MR angiogram doesn't show any issues, then it's probably not right to expose the patient to all that radiation until we get that person to see someone who can dig their teeth in and say, aha, I think it might be this. Daniel, Atlas in alignment, getting relief with some symptoms, only held 1 week. So Daniel, I don't recall your other comments. I apologize on not really understanding the context there. Nicole, thanks so much. Beverly, I passed out several times tonight, especially if we sleep my neck, horrible panic and burning, head, neck, shoulders, and chest. Yeah, so Beverly, like I said, that's something definitely to get worked up. And the first part of that would be doing a telemedicine evaluation to see if there's other studies that might need to be obtained. Rob, hope this all makes sense. When having regen injections, is there a facet misalignment? Does new tissue eventually pull back the joint into place? So if there is a facet misalignment, the concept would be that once the tissue tightens, it'll generally get pulled back into place. Sharon, I'm a pro pianist. Can I play my piano daily after PRP procedure without destroying anything? Yeah, so Sharon, those are activity as tolerated procedures. So if specifically playing the piano doesn't bother your neck, then you can do it. So that's how that would go. Okay, guys, so we're coming up on 1 hour and 3 here. I've got a hard stop at 2, and it's 2:04. So thanks so much for watching, everyone. I will be here broadcasting on all 3 channels, YouTube, the Centeno Schultz Facebook, and the Regenix Facebook on Friday. And that'll be the same bat time, same bat channel, which is going to be 1 p.m. Mountain. And that's 12 p.m. Pacific or 3 p.m. Eastern or 2 p.m. Central. And happy to answer any questions you have at that point. You can also leave questions here I haven't gotten to. And our Facebook person, Carol, will bring them over to next week. So those will be the first questions I get to next week. So thanks so much for watching. It's great to be back with you all after 2 weeks. Being down in the Caymans was nice, but it's also nice to be home too and doing all this stuff again. So thanks so much for watching and have a great day.